Welcome back to our Explainer series, Decode Healthcare with Harshal. If you've been following along with us, you know we've been systematically breaking down acute, life-threatening conditions. In part 2, we tackled coronary arterial occlusions, those severe blockages right at the heart. Well, today we're shifting gears to part 3, and we are exploring a massive, highly critical topic, acute pulmonary vascular blockages. We're talking about pulmonary embolism, or PE, and we're going to see exactly how the intense clinical reality of this condition translates into high-specificity ICD-10 coding. Let's get right into it. So I want you to think about this absolutely terrifying scenario. A patient has a completely silent, asymptomatic blood clot sitting in their leg, and within literally minutes, they are in sudden, fatal right heart failure. How on earth does that happen? And from a clinical documentation standpoint, why does missing just 3 simple words, acute cor pulmonale, lead to severe coding underreporting that completely ruins the severity scoring for that patient? We are going to decode exactly why. Here's our quick roadmap for today. We'll cover the anatomy of a PE, the clinical red flags, emergency treatment protocols, ICD-10 coding specificities, a real-world clinical case study, and finally, our golden rules. Section 1, Anatomy of Pulmonary Embolism. Let's look at the raw physiopathology. Imagine the migration pathway of this clot. A deep vein thrombosis, which is a blood clot usually forming quietly down in the deep veins of the lower legs, suddenly breaks off. The moment it breaks off, it becomes an embolus. It travels rapidly up through the body's venous system, passing right through the inferior vena cava, entering the right side of the heart, and then it gets pumped out directly into the pulmonary arterial tree. That's where it wedges itself into the increasingly narrow vessels of the lungs, completely blocking blood flow. So following these sequential steps, we see the true mechanical danger. Step 1, the DVT detaches. Step 2, it causes sudden pulmonary occlusion. Now, because that blood flow is suddenly obstructed in the lungs, there is a massive spike in pulmonary vascular resistance. The right ventricle of the heart, which, by the way, is only built to pump against low pressure, suddenly hits a brick wall. And that leads directly to step 3. Acute right ventricular overload. Medically, we call this acute cor pulmonale. The right side of the heart rapidly dilates, strains, and fails. Section 2, recognizing clinical red flags. Time to identify the immediate warning signs. When a patient rolls into the emergency department with unstable vital signs, pointing to a potential PE, this is a massive blinking red flag. It represents a critical signal failure of both the cardiovascular and respiratory systems. This is a time-critical emergency requiring rapid diagnosis and immediate decisive intervention. Why? Because any delay here means survival is highly unlikely. Time is quite literally tissue. Notice how these specific hallmarks should instantly trigger suspicion of a PE, even before any imaging is ordered. We are looking out for sudden onset shortness of breath, pleuritic chest pain, which is that sharp, stabbing pain when they try to take a breath, a sudden cough, or even hemoptysis, where they are coughing up blood. Crucially, pay close attention to the vitals. Unexplained tachycardia, severe hypotension or syncope, which is fainting. These vital signs absolutely scream that the right heart is failing to push blood forward. Section 3, Emergency Treatment Protocols. Let's talk stabilization. Before we can even think about getting to definitive therapy to fix that clot, we absolutely must stabilize the patient. This involves immediate high-flow oxygen therapy to combat hypoxemia. But notice this next point carefully. Judicious, meaning extremely cautious, IV fluid administration. You might be wondering, why so cautious? Well, because the right ventricle is already heavily strained and backed up. Pumping them full of IV fluids could easily cause fatal right ventricular fluid overload. And of course, continuous hemodynamic monitoring is absolutely mandatory here. So the crucial decision point is choosing the right definitive treatment pathway based on the patient's stability. On one side, our cornerstone therapy is anticoagulation. We immediately initiate therapeutic heparin, whether that's unfractionated or low molecular weight. Now remember, heparin doesn't actually dissolve the clot. It just halts thrombus propagation. It stops it from getting any bigger while the body's own systems clean it up. Eventually, they'll transition to oral DOACs or warfarin. On the other side, we have emergency thrombolysis, using IV fibrinolytics like alteplase. This is the nuclear option. It actually dissolves the clot, but it comes with major bleeding risks. So it is strictly reserved for massive PE scenarios where the patient is suffering from sustained hypotension and cardiogenic shock. Section 4. ICD-10 coding for PE. Let's translate this into coding specificity. Remember the core rule of coding acute life-threatening conditions. Acute PE must be sequenced as the principal diagnosis if it's the main condition established after study that caused the admission, but you simply cannot stop there. The coding rules mandate that we identify and sequence secondary codes to capture the full severity of what the patient is going through. This means explicitly coding the underlying lower extremity DVT, any acute respiratory failure, and coding for hemodynamic shock if it's present. Now, the distinction between these specific codes is a real game changer for your documentation. The entire difference between code I26.0 and I26.9 comes down to one clinical concept: acute core pulmonale. If the physician documents right heart strain, which is usually picked up on a bedside echocardiogram, you must code I26.0. That code carries a significantly higher severity weight. If that documentation is missing, well, you're forced to drop to I26.9, PE without acute core pulmonale. We also have codes for chronic resolved PE, which is I27.82, and specific complication codes like T81.718 if the PE happens following a surgical procedure. Section 5, Clinical Case Study. Let's anchor this to a real-world scenario. Let's trace this case step by step. We have a 58-year-old postoperative patient who suddenly develops dyspnea at hour 0. By hour 1, they're showing unexplained tachycardia and pleuritic chest pain. Yep, those classic red flags we just talked about. At hour 2, the critical diagnostic moment occurs. A bedside echocardiogram clearly demonstrates acute right ventricular dilation and strain. Because of this specific clinical evidence, they are rushed to the ICU at hour 3 for IV heparin treatment. And for our clinical documentation specialists, that exact echo finding is the golden clinical justification needed to select code I26.0, perfectly capturing the life-threatening severity of the situation. Section 6, Golden Rules, are key takeaways to implement immediately. All right, here are your 3 golden rules for pulmonary embolism. Rule 1, always code acute PE as the principal diagnosis when it's the primary reason for admission. Rule 2, aggressively look for and query for core pulmonale or right heart strain in the chart to ensure you secure that highly specific I26.0 code. And Rule 3, always code the associated secondary conditions to paint the full clinical picture. Don't forget to capture the underlying DVT, capture the shock, and capture the respiratory failure. Following these rules ensures that the severity of illness on the medical record perfectly matches the vascular crisis that just unfolded in the ER. Before we wrap up, I want you to ask yourself, how many times has right heart strain been noted in a chart at your facility, but acute core pulmonale was completely missed in the final coding? It's something to think about. Now, if a silent leg clot can travel to the lungs and cause fatal heart failure in minutes, what happens when the heart's electrical system completely short circuits, or when the largest artery in the body suddenly tears? Join me for part 4 of our explainer, where we'll dive into lethal cardiac arrest rhythms and massive vascular catastrophes. Until then, keep questioning, keep learning, and keep decoding healthcare.